Well, I'm going to be thinking about time and connection all day today and how we give people that as we think about everything else we're trying to do for them. We're going to switch modes quite a bit now and really we're going to spend some time kind of deconstructing this a bit and make it not human. And we will come back to the human part. So I want to be really clear about that. We're going to sort of get into, I want to make sure we have some sort of fundamental understanding of what's going on. Oh, Sara and Vanessa, would you please come up and join us up here? Sorry. In that line, we're going to talk about the scope and impact of methamphetamine use in Washington State. I'm going to moderate, and I'm going to be the first speaker. Twofer. And you're welcome. So I do want people to have a general sense of what's going on. And I'll just share with you also sort of my personal work is I was very blessed to start working with people with opioid use disorder in 1995 with my friend and colleague Ron Jackson, who you'll meet in a few minutes. And my first research job in 1996 was working at the Alcohol and Drug Abuse Institute, interviewing people with methamphetamine use disorder who were also men who have sex with men because of the incredibly high prevalence of HIV among folks who use meth and inject that methamphetamine. And some things have changed and some haven't. And the challenge you'll see with methamphetamine I'm about to share with you is, unfortunately, it's spread even further, is really what you're going to hear. It persists, and there are particular issues around HIV infection that we need to continue to be really mindful of, as well as other infectious diseases. But this is different. Sort of everything I thought I knew and understood about methamphetamine 23 years ago, most of it was wrong, as usually is the case. And it's just evolving. There's a lot more to know. So I'm going to share with you a couple of high-level things, and also I'm going to mention to the folks here, so when this is being recorded, don't use the pointer, use the mouse, because apparently the pointer is invisible to the video camera. So I'm using a mouse. And all of these are online. I just want to let you know. So this is looking at mortality, right? And this is what Scott's story was about a couple of weeks ago. And it is really quite striking what's happening, and I want to unpack it a little bit because it's really important. And very different than what I saw when I started taking over the drug epidemiology work in 2001. Because of this work, actually. So this black line at the top here is all drug-involved overdose deaths. So these are acute overdose deaths. This is acute intoxication. This is not injuries. This is not violence. This is the most narrow sort of definition of deaths due directly to overdose. So the black line is all drug poisonings. The red line is opioids, which is a topic for yet another conversation, because you'll see that we are doing a lot of work, and I would argue we've done a good job of not letting continue to escalate. There's a whole other day, many days, we'll be talking about how do we get that line down. But then what I think really stands out here are these two blue lines. The light blue line is cocaine, and the dark blue line, or the darker blue line, is methamphetamine, which is really quite striking increases in methamphetamine overdoses just in the last 6 years. Terrible graph, I apologize. But let me just give you an orientation here. In the second column here, you can see the number of deaths in Washington State. Went from 89 back in 2003 to 476 last year. So a dramatic change. Age has stayed pretty similar. Folks in their early 40s is the median. We have a significant, but a minority of folks are women. This is important as well, and this is one of the things, the truisms that is not true anymore, is that we thought of it as a white drug, and it's no longer just so much a white drug. It's really changed, as you can see here, from about 91% white to about 78%. And you can see increases among African American, Native American, Asian Pacific Islander, and Hispanic populations. Also to share with you, and you'll show you a slide on this in just a moment, a substantial minority, almost half of deaths are with opioids, and that hasn't changed over time. So these epidemics, from my perspective, really kind of are moving together in terms of we have both methamphetamine deaths all by themselves and methamphetamine with opioids. These two sort of epidemics intersect with each other. And to that point, this is looking just among methamphetamine deaths in Washington State. You can see the substantial increase in the rate. And the two main things to look at here is the shading that is orange. That's opioids plus methamphetamine, with or without other drugs. And the blue is methamphetamine without other significant drugs. So again, this sort of 50-50 ratio over time, which means we have two things going on. We have an opioid epidemic and we have a methamphetamine epidemic, and they intersect. Just to give you a sense of where we see things happening around the state, And this was the case when I was brought in 01, and I was hired in 01, thank you to then Division of Alcohol and Substance Abuse, because of methamphetamine and because we were tracking drug trends in just Seattle, King County, and guess what? Methamphetamine was everywhere, just like now opioids is everywhere, just like now pretty much everything is everywhere. And you can see some of the higher rates back then. They don't necessarily pop on this slide, but some of the highest numbers and rates are in places like Grays Harbor and Spokane, Vancouver, Clark County, places like that. So it is across the state, but you can see this increase. And it's important as well is that the largest increase, although it's substantial, isn't in King County. So we may not have had as much attention, and as we know, media is often driven towards and focused on the Seattle metro area. So this story is kind of coming late, and you can see there are other parts of the state getting hit quite hard as well. Of course, King has the most numbers of folks who are dying with methamphetamine-involved deaths. This is just to show you one sense of what's on the street. So there are many ways to go at this. This is police evidence that's sent to the state crime lab for testing. And so you can see that blue line at the top, there's methamphetamine. You can see what was going on back in 05. That's, of course, the peak of when we had local manufacturing of methamphetamine. And we squeezed that balloon to Mexico, and it has popped back up. And they've said, thank you, we'll make that methamphetamine. We're going to make it better, cheaper, and more pure, way cheaper and way more pure, and we're going to give it back to you. And that's what's happening. And the numbers aren't quite as high. I think that has to do more with the fact that we're not having as much of the manufacturing type crimes as well. But a substantial return in terms of what we're seeing on the street. And when you talk with our law enforcement partners, they'll often say, it's terrible what's happening with heroin, but what makes my day rough is the methamphetamine and how that gets manifested. And they're very different substances, and people interact with them and they present differently with those different substances. And then this is looking at the crime lab. These just mirror each other in terms of where we're seeing the drugs on the street. And I'm going to skip that one. And I'm just going to mention this. These are the publicly funded treatment data. Actually, do I want to go back? Oh, I am going to go back, sorry. So the methamphetamine treatment admissions, that's again that blue line, again kind of peaked in 2005, really declined, and are slowly making their way back up. So it's a major drug involved in treatment admissions, and we're definitely seeing some very similar patterns. All of these patterns are moving together. What is striking is the substantial difference in mortality that we're seeing now. And I believe that it's largely to do with both the form of the drug and that we have a lot more people actually using it. We don't have good, I should mention this, I'm not even going to show you population survey data because I wouldn't believe them if I had them for methamphetamine. But I think, talking about tip of the iceberg, the mortality is really telling us what's going on. And then these are the publicly funded treatment admissions. More recently, there's been a lot of changes. That line is showing really substantial changes in our state data treatment system. You can see the bottom here, heroin and other opioids in blue and orange. You can see alcohol actually declining as a proportion, marijuana also declining as a proportion, cocaine also declining as a proportion, and somewhat of an increase in methamphetamine over time, to give you a sense of what we're seeing in those drug trends. I think I'm going to leave it there and hand it over to Dr. Vanessa McMahan. She's been a doctor for a week and a half, and she's great.
Wow. Thank you, everyone. Good morning. As Caleb said, I just finished my doctorate, and today I'm going to talk about the 3 different papers in my dissertation at different times that all relate to methamphetamine. The first one I worked on with Caleb, and its key findings from the 2017 Washington State Syringe Exchange Health Survey that's put on by ADAI. And we're going to talk about interest in reducing or stopping methamphetamine use. Okay, do I do the clicker, Caleb? Okay, there we go. So the aims of our study was to identify if sociodemographic characteristics, drug use behavior, and concern about mental health were associated with interest in reducing or stopping meth use among folks who said their main drug was meth. The second aim was to explore the types of help people wanted of those who were interested in reducing or stopping their use, and then we contrasted those findings with folks who said that their main drug was an opioid. So the data source is a 2017 Washington State Syringe Exchange Health Survey. This is done at syringe exchanges across the state, and you'll see, I'm gonna use the pointer, here's an image of respondents by zip code and syringe exchange location. So I think kind of unsurprisingly, we see this concentration in the I-5 corridor, but there is also representation from Eastern Washington as well as the Peninsula and Southern Washington. So the survey is done every 2 years, and it is a 50 items paper-based survey. It's done interviewer administered, mostly by the syringe exchange personnel and volunteers. It includes information on demographic characteristics, sex partner gender, drugs used in the past 3 months, injection-related infections like MRSA, cellulitis, or endocarditis, source of health care, so we ask about use of ER, tribal health care, doctor's office, other no care in the past year, Concern about mental health, we asked if people had a concern about depression, anxiety, or some other mental health issue. And then drug treatment, if people are currently receiving drug treatment. So the outcome for this study was 2 different questions, because we looked at people whose main drug was methamphetamine separately than folks whose main drug was an opioid. In the first group, we asked, how interested are you in reducing or stopping your stimulant use? And in the second group, how interested are you in reducing or stopping your opioid use? There were 4 answer options. So I'm not interested, I'm somewhat interested, I'm very interested, or I'm not sure. We looked at very and somewhat interested collapsed as one answer option of just interested, compared it to folks that said they were not interested. And for not sure, we looked at it, but we didn't really use it in our primary analysis because it's kind of hard to interpret. If you're not sure, are you more interested? Are you less interested? We just didn't know really. So we left those folks out of the main analysis, but we looked at them descriptively. So the covariates from the survey that we tried to assess to see if they were associated with interest in reducing or stopping use were demographic characteristics of age, race, gender, cisgender, men who have sex with men, housing status, rural or urban location, health insurance status, legal monthly income, drug use, so overamping for folks that did meth, overdosing for folks that did opiates, injection-related infection, other drugs used, past year source of health care, concern about mental health, and past year incarceration. So this is a little bit in the nitty-gritty, but just so you kind of know which participants we're talking about, because we actually had a lot of conversations around kind of who do we want to look at in this analysis. So we took all the survey participants, it was 1,079. We excluded 171 who are currently in treatment because we were looking at interest in treatment among folks that were actively using, so they weren't really part of the sample. Then we excluded 81 participants whose main drug was neither opioid or methamphetamine. And then we excluded 251 participants from King County. And the reason we did this is because we wanted to include concern about mental health, and that was not in those surveys. We excluded 1 person that said they had other gender that was not male or female for the small sample size. So this survey was almost exclusively people that identified as male or female. Then we had 208 people whose main drug was methamphetamine and 367 whose main drug was an opioid. We further looked at these 2 groups and excluded some more folks. For the folks that reported methamphetamine as their main drug, we excluded 19 who used another stimulant, so crack, coke, or speedballs, because the question we were looking at is how interested are you in reducing your stimulant use? And we really wanted to focus on meth. And someone might be doing meth and crack and be thinking about their interest in reducing their crack use. So we're trying to isolate folks that are talking about meth. And then we took out the folks that said that they were not sure, which was 25. Similarly, we took out 30 people in the opioid group who said they were not sure. So we ended up with 164 syringe exchange participants in the methamphetamine group, who again reported meth as their main drug, and 337 in the opioid group. So this is a little hard to see maybe, sorry about that. So this is polydrug use. So of the 501 folks we had at the end, we looked at it by main drug use, which is right here on the left-hand side, so the top row is meth, then heroin, prescription opiates. So we took that opioid group and just looked at how many people are saying their main drug was heroin, which was the vast majority, 331 out of 337, and how many are reporting prescription opiates as their main drug, which was a very small minority. And what you'll see here is if you look at, these are the drugs used in the past 3 months. So everybody that reported a main drug had used it in the past 3 months. Also not really surprising, but just kind of looking at, are people saying something's main that they haven't used for a while, or kind of what's the recent use. So 100% of the main meth folks had used meth, 100% of the main heroin folks had used heroin, and similar for opiates, prescription opiates. What else I thought was interesting here is if you look at the folks whose main drug is methamphetamine, is there's more kind of just meth use. So you see about a third say they also used heroin, 11% said prescription opiates, 4% said fentanyl, 23% said goofball. But if you look at the second row for folks that's main drug is heroin, higher proportions are using other drugs. So 81%, which is the majority, used methamphetamine in the past 3 months. A third use prescription opiates, 12% fentanyl, and half are reporting goofball use, which we've been talking about this morning. So kind of more polysubstance use among the folks that use opiates. These are the demographic characteristics of the study sample. The total is on the left-hand side. Methamphetamine group is in the middle, and opioids are on the right. The boxes are trying to pull your attention to what was significantly different between groups. So age was different. In the main methamphetamine group, people tended to be older, not by a lot, but they were older by a few years. And the group tended to be more male. So there was a higher proportion of men in the meth group than in the opioid group. As far as men who have sex with men, this is cisgender men who have sex with men, Small sample overall, only 4% of the respondents identified as MSM. However, of those 18 respondents, 11 of them were in the methamphetamine group. So there was a higher proportion of people who are MSMs reporting methamphetamine as their main drug. And then for insurance type, we saw that the folks in the methamphetamine group tended to have more public insurance. Finally, there are continued demographics. At the bottom are the ones that were significantly different. If you look at past year incarceration, there was a smaller proportion of people using meth that was incarcerated in the past year, which I actually found somewhat surprising, was trying to tease out why that was. And then concern about mental health. Across the board, we saw, 60% of people said that they were very or somewhat concerned about mental health, and that was higher in the heroin group, or opiate group. And I'm gonna go ahead for time's sake. Here we just show the significant bivariate association. So of all those variables, which ones were associated with interest in reducing use by each group. The methamphetamine group, 86% were interested, so about 52%, so the majority, but the slight majority. And those folks that were interested are here on the right-hand side. They tended to be younger and more unstable housing and very or somewhat concerned about mental health. In the opioid group of 337, 84% were interested in reducing their use, and insurance type was significantly different, with folks in public or government insurance being more interested. And then again, we see this concern about mental health being related to interest in reducing or stopping use. So we did a final model where we put all of our variables in to look at which ones popped out to be associated with interest in reducing use, and really similar results. In the fully adjusted model, about 3.04 times, so people that were concerned about mental health, either very or somewhat, had 3.04 times the odds of interest in reducing or stopping stimulant use, and 3 times the odds of interest in reducing or stopping opioid use. In the meth model, there was nothing else that was significant. In the opioid one, source of care using an ER was also significant. But really similar magnitudes and really similar findings in these two groups. So finally, around the data, this is what types of health people want to reduce among folks that are interested. You'll see at the top, so the gray solid bars are methamphetamine and the striped bars are opioids. At the top, you'll see mental health care or medications was the #1 choice for people using meth as a main drug of what they wanted to reduce their use, with about a third saying that they wanted mental health care or medications. It is significantly different from the opioid group, with quite a bit fewer folks reporting that they wanted that type of help. At the bottom, if we jump, we see the #1 thing that the main opioid group wanted to help reduce their use, and it's methadone, buprenorphine, or naltrexone. We did not have an analogous answer option for the methamphetamine group because there's no currently approved medication for methamphetamine reduction. However, people did say at 20% in that middle bar, so 1/5 in the methamphetamine group, that they would be interested in medications to reduce their use. More of a theoretical answer because we don't have them currently, but there was interest. So finally, I'll just wrap up with implications in future work. So the implications is that, over half the sample that used methamphetamine as their main drug were interested in reducing or stopping their use. So things that we think is that people should be asked about this. If they're engaging with services, they should be asked and supported as appropriate. Mental health care was the most significantly associated thing with interest in reducing use, mental health concern. And of those that were interested, they wanted mental health care more than anything. So mental health practitioners, we think, should be part of this conversation and should be working with folks to see how they can help and support them reduce their use. Finally, there's interest in medications. About 1/5 said they were interested, and this research should be a priority. It's ongoing. There is research out there, but I think there's really a need to get medications to folks that need them. And finally, future work. The relationship between mental health and methamphetamine, it can be both causative and treatment. People can use methamphetamine and it can be causative for mental health issues, or be using methamphetamine to treat their mental health issues. And we really don't, I think, know how to engage with folks around mental health and what services they need. So more work should be done in this area. We lump together depression and anxiety, which could be very different experiences for folks. So I think asking about those separately is important. We didn't collect data on frequency of meth use, which could actually really impact people's interest in reducing their use, so that should be collected in future work. And maybe taking apart reducing and stopping use and looking at them separately, because reducing use is not the same thing as stopping use. And finally, we had very few folks that were only smokers, because we were at syringe exchange programs, so most people were getting needle exchange services. And so looking at folks who are smoking and trying to understand how they would maybe want to reduce their use, or folks that aren't engaged at syringe exchanges, because people outside of those services could have even a higher acuity around their methamphetamine use. Okay, I'm done, sorry. Thank you to the University of Washington and Washington State Department of Social and Health Services.
One quick thing just to mention that I didn't mention in my trend slides is that about a third of people presenting to treatment are injecting and about 2/3 are smoking. So that's really important context that this is from Syringe Exchange. We're really talking about people who are injecting. There's a phenomenal amount of smoking going out there as well. So I'm really happy to introduce Dr. Sara Glick, who's a research assistant professor in allergy and infectious disease here at the UW, and also gets to hang out a ton at Public Health Seattle King County and is a wonderful partner on the statewide Syringe Exchange survey, and we're changing some of the questions, thanks to you. So if you're hanging out at Syringe Exchange next week, please fill out our survey. And let me introduce Dr. Glick. Thank you.
I know this is supposed to be the non-human portion of the day, but I like to think of myself as an epidemiologist with a heart, so hopefully you'll see that. I thank you so much, Caleb, and everyone at ADAI for inviting me to speak today. I will be talking about meth use, HIV, and MSM here in Seattle, Washington. In behavioral surveys that we've conducted in King County of MSM, we find that about 15% of those participants report using meth in the past year, and that includes both injection and non-injection. In the small subgroup of MSM then who do use meth, we continue to see a very high prevalence of HIV. In recent data, it's anywhere between 40 and 45% of those men are positive with HIV. And that's in comparison to about 19% of other MSM in these surveys, 3% of people who inject drugs who are not MSM, and less than 1% among heterosexual folks. So in that group of MSM who use meth and are living with HIV, how are they doing? Our surveillance data don't do a great job of collecting ongoing meth use. So one of the ways we can look at this group is looking specifically at MSM who inject. Of course, not all of them use meth, but most of them do. So first of all, let's look at viral suppression. So viral suppression is important because it keeps people healthy, feeling good, and it also prevents transmission to their partners. So among people who inject drugs, both non-MSM and MSM, we have about an 80% viral suppression rate and about an 87% viral suppression rate among all MSM. And this is very high nationally. So if you look outside of King County, all of these numbers look very good. And how are folks doing getting virally suppressed? How quickly can they do this? Well, among our two MSM groups, people are getting to viral suppression pretty quickly, on average at about 4 months after their diagnosis, and that's in comparison to a much longer time among other people who inject who are not MSM. So as Caleb mentioned earlier today, there have been increasing trends in meth use across our state. And so a couple of years ago, we did a paper, along with Caleb, to unpack this a little bit more, because what we were really concerned about was if meth was increasing in groups outside of MSM, there could then be the potential for bridging, right, between these populations if there was injection equipment sharing between them. Because we know we have a high prevalence of HIV among MSM who use meth and a lower prevalence among non-MSM who use meth. And so if they're sharing equipment, there's the potential for HIV to move between these two networks. So we focused on people who inject because that's where we had some good data. And we have two different surveys, the National HIV Behavioral Surveillance Survey, and then the survey that Vanessa just talked about that we conduct in syringe services programs. So when we look among people who inject, and we focus on MSM, not surprisingly, a lot of them were using meth, right? This didn't come as a surprise. But what was very evident from the data was that this steep increase was occurring among non-MSM. And so we were really concerned about the potential for this bridging with HIV. So what we did is we looked at injection equipment sharing a bit more closely. So first, when we look at people who report any injection equipment sharing, you can see that about half of the MSM in this survey of injection drug users reported this, and about 74% of non-MSM reported that. When we look at just syringe sharing, about a quarter of MSM reported this, and 42% of non-MSM reported this. And then I think it's important to note that in both cases, MSM report less sharing than other folks. So then we're interested in, are these groups connected in any way? So the survey also asks people about their last injection equipment sharing partner. So among our MSM participants, over here who inject meth and shared a syringe with somebody. 43% of them reported that their last sharing partner was a non-MSM. And among the non-MSM participants, 11% of them reported that their last sharing a partner was likely an MSM. So this shows some evidence of the potential for bridging between the two groups. So this got a little attention, a nice little blog post, but the headline here was a new population may be at risk for HIV, and here's why. So that was that. And then, unfortunately, about 7 months later, we had this. And I'm sure most of you have heard about this either through your work or through the media or through your friends, but we have been experiencing a significant uptick in HIV among people who inject, including some clusters in certain parts of town, including North Seattle. So the question then is, did what we thought might happen actually happen? So let me walk you through a little bit of data to try to answer that. First, I'll walk through some surveillance data. So these come from our health department. And the way we do things at the health department is when somebody's diagnosed with HIV, we ask them about their potential risk factors, and they are categorized into certain groups based on those risk factors. So two of those groups that I'll be presenting on include people who report both being an MSM and someone who injects drugs. So those are the MSM PWID, and then someone who just reports injecting drugs. So those are the other PWID. So first in green, let's look at HIV trends among MSM who inject. Over the past 10 years, the average has been about 19 new cases per year here in King County, but we had this nice slight decline over the past 5 or 6 years. So last year we had 24 cases, so it's higher than average. This could be a blip, it could be real, it could be the result of increased outreach testing as a response to our outbreak. I think more years of data will help put this into better context. What we've seen among other people who inject, however, has been a more constant low number of new cases per year, about 10 per year. But it was in 2018 where we saw a very significant increase of up to 30 new cases. So in total, we had 54 new cases among people who reported injecting drugs. And so together, that really represents a significant increase from previous years. Recently, our group published a paper in the CDC's MMWR. So if you're interested in getting into more of the nitty-gritty on cluster detection and outreach efforts, you can take a look at that paper. It's publicly available. And so this is just a graphic from that. I'm not going to go into detail with the graphic, but we use various types of investigations to learn if people are connected with one another. And in this largest cluster that we've detected, there were no MSM. So this suggests that at least we don't have evidence to support the fact that it might be this bridging that we had hypothesized might be going on. However, what is very clear is that there are profoundly high rates of homelessness in this group. Almost everyone reported living homeless. And, in the spirit of today, almost everybody reported both heroin and meth use. So in conclusion, what Caleb said just a few minutes ago remains true. MSM continue to remain at high risk for HIV, particularly those who are using meth and those who are injecting meth. But also non-MSM who inject, and especially those living homeless, are among a group that experienced an HIV outbreak last year. And so I know my talk was supposed to focus on MSM, but it would be, I think, a disservice not to talk about this group as well. And there has been limited evidence to date on this bridging between the two networks. Seattle's not alone. A lot of cities are experiencing similar types of upticks in HIV among people who inject, so we can learn from them as well. Now, these new cases among people who inject, it happened despite the fact that here in Seattle, we have probably the most robust overall syringe services programs in the country. I'm pretty sure we distribute more needles than any other city in the country, maybe the world. And also we have among the highest rates of viral suppression among people living with HIV. So the fact that we saw this outbreak despite these really shows you just how high of a bar we have. I think these findings certainly highlight the need for a lot of ongoing work. I co-facilitated a focus group earlier this week among people, most of whom are currently injecting drugs. And when we asked them what they needed to stay healthy, the number one answer was housing. So we see that in our surveillance data as well. And so first and foremost, we really need to think about how to give folks housing and how to give them additional economic opportunities. Second, we learned that even though we have lots of needles being exchanged and distributed, we need more and we need better coverage. So we need to think about the areas that have not historically had a lot of access and think about ways to get folks access. We need to think about and continue to be innovative and think about flexible approaches for keeping folks in care if they are living with HIV in order so that they can maintain viral suppression. And then finally, as Vanessa will talk about later this afternoon, for some people, particularly MSM who use meth, PrEP may be a way to keep them at lower risk for HIV. And we'd also like to think about maybe there are some other groups of people who inject who might be good PrEP candidates as well. So thank you so much for your time. Thanks to my colleagues at UW and Public Health, as well as, of course, all of our survey participants who are so generous with their time and their stories. Thanks.
So we're going to have a couple minutes for questions. I do want to use my moderator privileges to remind myself of my own omission in planning this day. And I think in a lot of ways, I want to mention that I think I have taken for granted syringe exchange. We have several dozen people here working in syringe exchange, and we can't. We have syringe exchanges that are closing and under threat around Washington State, and I think it's important to remember that the reason we have such low HIV prevalence and incidence in Washington State is because we've had syringe exchange since 1988. Those things are interrelated to each other. So that is another thing I think we need to keep in mind is just the need for syringe exchange services. I can't remember the numbers. I know we've had at least 17 million syringes exchanged in Washington State last year. 17 million syringes exchanged. Okay, we have a couple of minutes for any questions that folks have about what is going on in terms of the numbers and trying to understand what are the dynamics in different populations around the state. So if folks have any questions or comments on that, they are most welcome to ask them. Wow, we sated everybody's desire. No, please. And if you don't mind introducing yourself when you ask a question or a comment, we'd really appreciate it. Thank you.
Hi, I'm Rebecca Clay. I'm a nurse practitioner with Harborview Downtown Programs. And I was curious with the HIV uptick, if there's been any look at women who have sex with men in particular as a group that may use drugs, may not use drugs, maybe smoking, not injecting, but whether the uptick is related to more high-risk sexual behavior.
Yeah, that's a terrific question. There were several people in the cluster who reported those behaviors. So we do think that that is part of the uptick. About 3 years ago, we conducted one of our NHBS studies on that, focused on that population, focused on women who exchange sex for money or drugs. It included about 2/3 of the women did report injecting, but a lot of women did not report injecting. The HIV prevalence in that group at that time wasn't particularly high. So it was also, several years before we noticed this outbreak, so I'm not quite sure what we learned from that. But certainly that has been, focusing on that population has been part of the outreach efforts that the health department is engaged in. Yeah.
Any other questions? I see one in the back. I see one there and one there. Why don't we take those two questions and then we'll break.
Did you get hers?
Yeah, Rachel.
Oh, is there one there too?
I'm Roberto from Consejo Counseling Referral Services. Does any of your statistics, when it shows with meth, break down the ages, especially among young people, 20 and under?
I don't think I have great data on really young adults and adolescents. There certainly is, I can sort of say more anecdotally, we certainly know there is plenty of use among younger folks, particularly homeless folks. And we know there are some interrelated motivations around people who are homeless, including things around the properties of meth. I have been quoted accurately, but maybe not quite clearly, as saying that meth is a great drug. That is an accurate thing to say in the context of people's lives, right? And so in the context of a person who is poor and homeless, the idea that having something that is an appetite suppressant and provides you energy and makes you feel good and protects you from violence at night, those are things that we see in particular among young adults who are homeless. I think that's a common phenomenon. I don't know that I have any great statistics on sort of the size of that population locally. Do you?
Our surveys, unfortunately, have a minimum age of 18. Health department data, of course, would have ages of people newly diagnosed with HIV. I don't think we've been seeing a large number among teenagers. Somewhat related to this, though, we asked people an open-ended question: why do you use meth? And we heard a lot of people say that they were self-treating their ADHD. And that, of course, I think has its roots in being young and adolescents and people maybe not continuing to stay on their medications into adulthood. I'm not sure.
And I think there are implications later we'll talk about also in terms of pharmacology and medications about are there particular populations that might benefit from certain medications if they have ADD. Was there another one or two questions?
Hi, Sasha Waring. I'm a child and adult psychiatrist, and I'm also the behavioral health medical director with Coordinated Care, one of the managed care organizations. I had a question on Vanessa's study, and possibly this might be overreaching or a little bit outside the scope of your study, but I'm wondering about whether individuals' treatment histories, as far as what types of services they've previously accessed, affected, or if you don't know what you think, how that might affect their interest in future treatment services, in particular around levels of care, like inpatient, detox, residential, how that might affect their future interest in services.
Sure, thanks. So we didn't ask that in detail. Part of the survey is really about brevity as well, because it's done kind of outside an exchange on the street, so we don't get to ask everything we want to in detail. We did ask about drug treatment overall, and any detail of that was actually not part of my study because we were looking at active using folks and interests, so we excluded them. We could look at those folks in more detail. I also am a needle exchange volunteer and would say that in my direct service experience, I think that people's past experience in treatment can really color the way they look to the future. I have some people that I talk with that have had good experiences, and then something happens in their life where they just can't keep it up, but they actually are excited about maybe trying again. And then folks that have really bad experiences. And like, for example, especially with women where kids are taken away and families are separated, I think that's something that people are really fearful of. But because we excluded folks that had received treatment, we didn't include that in this particular study.
And I would say I think that's a great question from a research perspective to try to understand further. And also from an engagement perspective, we're doing a lot more, we're doing with opioids, but you could do it with any substance, around sort of shared decision-making, treatment decision-making, asking people, what types of services have you had in the past? What do you think about them? And why do you think that? Is it how you were treated? Is it the inconvenience? Is it the other people who were there? Really trying to unpack what it means when people say, I don't like that. And not just write that off as, oh, they're not interested in treatment. It's like, let's take some time and talk about, were there pieces of that you did find value in? And we also then try to think about how we deliver those services.
And just, can I say
Please.
one other thing? I think with meth too, people sometimes can't conceptualize what treatment could look like. And so it's like inpatient. I mean, my folks that talk about reducing their use, I think inpatient is kind of the only thing they can think of. And we do another study, we're trying to do peer support for folks, and there are limited services. So I think part of it is when you ask people, they might not really have an idea in their head of what that could look like, which makes it hard to answer, especially around meth. Whereas opioids, there are so many things that we have available that people are familiar with.
Let's take one more question and then break.
I can just do loud.
Okay.
I'm Rachel. I'm with DESC, Pathfinder program, and I just am wondering, if there's anything being done around sex work in particular, and MSM, or women who are exchanging services for money, and just how sex work plays into it, and if y'all are gonna. I'm just suggesting that be looked at, I guess.
I think that's a great suggestion. Is anyone from Aurora Commons here? I'm sure many of you are familiar with them. I think they've been doing the best work with reaching out to that population, and in partnership with some folks from Harborview, there's now some mobile medical services being provided to that population up on North Aurora. I will say MSM who exchange sex have not been necessarily on my radar, so I appreciate the recommendation to look at that. Yeah.
And relatedly, within Aurora Commons work that's happening, there's also some buprenorphine provision as well to address opioid use disorder as that intersects. So, great.
And I'll talk a little bit later about PrEP as one strategy to try to reach folks who are MSM and using methamphetamine amongst, and also some are sex workers. So that's one strategy.
And we're going to hear about Project Neon also. So, yep, great. Okay. I release you to your stimulant of caffeine. Please come back in about 10 minutes. Thank you.